Dr. Leah Millheiser is a clinical assistant professor and the director of the Female Sexual Medicine program in the Department of Obstetrics and Gynecology at Stanford University Medical Center. She is a North American Menopause Society certified menopause practitioner, and her clinical focus is on the treatment of female sexual dysfunction and the care of women in midlife and beyond. Dr. Millheiser has devoted her career to researching and treating all aspects of female sexual health. She has a particular interest in the sexual wellness of cancer survivors. In addition to her clinical work at Stanford, she currently serves as the Senior Vice President of Medical Affairs at Hims & Hers, a digital health company. Ladies and gentlemen, please welcome Dr. Leah Millheiser.
So this slide is just to say that whether you're a cancer survivor or not, sexual dysfunction and sexual concerns are very, very common. As you can see here, the most common is sexual desire problems. So women who have low libido. The most common thing that I see in my clinic in any postmenopausal patient and any cancer survivor is low libido. And that's because of there's a bunch of different factors that can contribute to that we're going to get into. So when we talk about sexual dysfunction, there really is a distinction to be made. There's actual sexual dysfunction, which is a concern that bothers someone. So I have a persistent problem and it bothers me. It's been lasting more than 6 months. That only affects about 12% of women. So true sexual dysfunction only affects 12% of women. But about 44% of women throughout the age range, in this study, they looked at women between the ages of 18 and 102, have a concern. And whether it's a concern or it's a dysfunction, doesn't matter. It all needs to be addressed because ultimately that concern or that dysfunction affects quality of life, whether for the woman herself or the woman in a relationship. So, what are those factors that we're talking about? So, there's a lot of things. And we'll talk how it specifically relates to cancer survivors, but in general, there are physiological factors that cause female sexual dysfunction or concerns. So there's hormone fluctuations. So that can be anything like a woman who is breastfeeding. When you're breastfeeding, your estrogen and testosterone are lowered and you develop vaginal dryness, sexual pain, low libido. A woman who's gone through menopause, same exact thing, lowered estrogen and testosterone. It could be a chronic illness like hypothyroidism or hyperprolactinoma that can cause low libido. It can be a neurological issue that causes decreased sensation in the genital area, difficulty achieving orgasm. It can be fatigue in general. Cardiovascular problems can affect blood flow. When you have blood flow affected that's going to the genital area, again, that's going to affect vaginal lubrication and ability to achieve orgasm. There's the psychological components. Depression. We know that a lot of women, obviously, who get the diagnosis of cancer or being treated for cancer may be experiencing a situational depression and anxiety. Those on their own can cause low libido. Any stress, psychological stressors, family stressors, anything like that can cause it. Substance abuse. A little bit of wine can be great for lowering inhibitions. A lot of wine or alcohol can affect sexual function in a negative way. Any kind of intimate partner abuse. So if you're the victim of intimate partner violence, that can affect your ability to be intimate. And then, of course, a history of childhood sexual abuse, physical abuse in general. All of those can affect sexual function. Interpersonal factors, so relationship issues, lack of a partner. So I have patients who come in who complain of low libido, and then they say, but I think it's related to the fact that I don't have a partner. Privacy concerns. Many of my patients who I see will have young children living in the home or teenagers living in the home, and will say, we just don't feel like we can get enough privacy. We're not necessarily comfortable putting locks on the door or locking the door, and that can affect it. And then, of course, sociocultural. This one is really, really important because we see patients in the Bay Area that come from certain cultural backgrounds or come from certain countries where they are not taught from an early age about sex. And in fact, I have PhD students at Stanford who will come to my clinic and say, I've never looked at my genitals before with a mirror. I don't know what it looks like down there. I don't know what sex is. I know you're supposed to do it to make a baby. I have no idea what it is. And these are people who are adults, right? Who are highly educated. But there was one aspect of their education that was missing while they were growing up. And that ultimately can cause a lot of inhibitions, a lot of fears, and issues around sexual function. Survivorship medicine, as you all know, it's something that you're in survivorship from the moment you're diagnosed with cancer. And it really is about the physical, psychological, and economic issues of cancer survivors. And it extends until the end of life. The issues that I see in my practice are the late effects of treatment. So, this is the woman who has undergone chemotherapy, radiation therapy. Maybe she's on an aromatase inhibitor or tamoxifen, and the effects of those treatments on her sexual function. And then, of course, quality of life. This is so important to say that for many women, when sex isn't working, when there's an issue related to sex in the relationship, when the relationship is potentially in trouble because of the lack of intimacy, that has a huge impact on a woman's self esteem and quality of life. So, these are the two things that I deal with in my practice. So, when we talk about cancer and female sexual dysfunction, it really depends on what type of cancer are we talking about, a reproductive type of cancer or a non-reproductive type of cancer. There's many different studies that look at the prevalence of sexual dysfunction in women, but if you look at the data, and I believe this to be true, that 50% of women with a breast or gynecologic cancer will experience long-term sexual dysfunction following treatment. The two most common things that I see are loss of desire, so low libido, and vaginal dryness and pain. When this is a study that was done, it was interesting. It was done in breast cancer patients and had to do with female sexual function. And they looked at almost 1,700 breast cancer survivors. And they asked them about their sexual functioning before the cancer diagnosis. And about 80% said they had a good or satisfying sex life. Within the first 2 years following diagnosis, 70% of those women less than 70 years old had a sexual problem. So we do know that sexual issues tend to be quite common in the first 2 years following treatment. And for many women, it gets better after that. But it's really important. And this is, at Stanford, we're very fortunate in that I'm very fortunate in that I work very closely with the breast team, the GYN oncology team. And so they know all the questions to ask. They know when to refer to a clinician who treats sexual function problems. The problem is that not all institutions have that. They don't have a sexual function person who necessarily deals with these issues. So maybe it's not coming up in those visits with your oncologist. Maybe you're not being asked about sexual function, which is why I always empower patients to bring it up with your oncologist. Oncologists are focused on keeping you healthy, keeping you alive, keeping the cancer at bay, treating the cancer. They're not necessarily focused on sexual function. So I always encourage my patients, if you have a concern, bring it up. If there's no one in your institution who treats sexual function concerns, then see if you can get a referral to someone outside. We do know that this is a really important issue to talk about because we know that, especially for breast cancer, the 5-year relative survival rate is so high. So we know that we're going to see so many women in survivorship for many years, and that these sexual function issues are going to be of the utmost importance. Younger women, so women who are diagnosed with breast cancer, and we'll be talking about breast cancer a lot. I will talk about other cancers too, but we're going to focus mostly on breast cancer. We know that younger women with breast cancer at the time of diagnosis, so premenopausal, tend to have more distress. It doesn't matter what age you are. If you're diagnosed with cancer, there is distress. But there is a more severe degree of distress in women who are premenopausal at the time of their breast cancer diagnosis. The concerns about body image, the concerns about fertility, about dating. I hear this a lot from my younger patients. Who's going to want to be with me now? Going through premature menopause in your 20s due to your treatment. Now, oftentimes, it depends on what kind of treatment they've received, but oftentimes women treated with chemotherapy in their 20s and 30s who go into premature menopause, it's temporary. They will eventually start cycling again. But this is a very distressing conversation to have, whether you're experiencing hot flashes, night sweats, vaginal dryness, painful intercourse. So always kind of focusing on, yes, it is distressing for any woman at any age, but especially those women who are younger. Compared to women who are older than 50, younger women tend to experience a poorer quality of life, more frequent and severe depressive symptoms, greater concerns around premature menopause, as we talked about, and greater issues with weight gain and decreased physical activity, which can be, of course, very distressing to the younger woman. They also looked at partners of cancer survivors. They looked at both reproductive type cancers and non reproductive. And those partners did report that the cancer did have an impact on their sexual relationship. 59% of the female partners and 79% of the male partners reported lack of or decreased frequency of sex and intimacy, which is very normal and very expected, especially early on. What these partners described was how the diagnosis affected them. Well, they were affected by just the treatment, the impact of the treatment on their partner, exhaustion due to being the caretaker, viewing the person with cancer as a patient rather than a sexual partner. These are all very normal and expected reactions from a partner. And oftentimes, the partner needs to be in some degree of counseling to deal with those emotions. It's very hard to go through the cancer, but it's also very hard to watch your partner go through it and know what to really understand what your role is. Is your role as the sexual intimate partner, or is your role as the caretaker, or is it both? And what we really try to get to is a point of it's both. It's the caretaker, but it's also you're still partners. You still need to keep that emotional bond, that emotional intimacy. And that's not always easy. We do know that relationships that have problems before the diagnosis, so if there's a couple who's having marital issues before or sexual function issues before the diagnosis of cancer, that tends to get more challenging after. I think people like to think cancer or medical illness will bring a couple closer, and that's not always the case. What ends up happening often is that the partner will keep things inside, or the person going through treatment will keep their feelings inside to not put it on their partner, to not upset their partner. There's changes in the way that conflicts are resolved, and oftentimes the couple will need an intervention either before the treatment starts or during treatment. That is something that is really important. So if you are going through, if you have a diagnosis of cancer and you're already experiencing sexual function issues, intimacy issues, marital issues with your partner, get into counseling early, before treatment, during treatment, because there's a chance that may get worse throughout the process. What are the treatments that have the greatest impact? Well, we know chemotherapy, surgery, hormonal manipulation, and that's with these adjuvant treatments that we see, especially with breast cancer survivors, aromatase inhibitors, tamoxifen, and radiation therapy. And we'll kind of talk about the impact of each one. So chemotherapy, obviously, side effects of that are alopecia or hair loss. Most women will expect hair loss, eyebrows, of the scalp. What a lot of women don't realize is they're going to lose their pubic hair too. And interestingly, that has a very negative impact on a woman's sense of femininity, sometimes more so than losing the hair on her head, because she can wear a wig or wear scarves or hats. For many women, especially prior to the whole Brazilian bikini wax thing in our culture, they didn't realize it. And to lose hair down there, they almost felt childlike, because children don't have pubic hair and they didn't have pubic hair. So for some of my patients, especially 20 years ago when I started this, would say, I don't feel like it's right to have sex. It just doesn't feel right to me because of how things look down there. They weren't worried about what was happening on their scalp. They were more worried about what was happening in the pubic region. Of course, that's not the same for everyone, but just to point out that it is a common concern that women have had over the years. Chemotherapy can cause fatigue. It can cause weight changes either up or down, which can ultimately impact body image. Neuropathy. So neuropathy, sometimes that's when you have like tingling and numbness in the limbs, sometimes pain. That can affect a woman's ability to get into certain positions that are comfortable for her to have sex. So for example, on all fours might be difficult. That can also be a challenge for women who have undergone radiation because they get stiffness in their shoulder joints. Obviously, infertility can cause, chemotherapy can cause infertility due to the ovaries stop working. So you're going through this sort of what we call chemo-induced menopause. That again can have a very negative impact on a woman's sexual self-esteem because it takes away her fertility and makes her feel less feminine. I don't agree with that. I'm just saying this is what women feel. And that's especially challenging for a woman who is single and who's not had children yet. Premature ovarian failure. So that is when you go through chemotherapy and you go through menopause as a result of the chemotherapy. We typically see this mostly with the alkylating agents, and most breast cancer patients or cancer patients will get an alkylating agent. So the outcome is often influenced by how long you were on the chemo, how much chemo did you get. Typically, what we see though for women getting these types of chemotherapy agents, if you're younger than 40, it takes about 6 to 16 months before your period goes away. If you're older than 40, it can take 2 to 4 months. Now, women who are younger than 40, when they go through chemo and experience chemo-induced menopause, they typically will get their periods back over time. Women over 40, it's plus or minus. This could just kick them into a permanent menopause state, but typically younger than 40, unless they're on a medication that stops them from getting their period, they will typically get it back. I am actually going to skip this slide because we talked about this, but just to keep in mind that, and I'm going to skip this one too, but just to keep in mind that, premature menopause can be very devastating to women of any age. It comes on fast and furious. You're not really expecting it. It's hot flushes, it's night sweats, it's insomnia, it's vaginal dryness, it's painful intercourse, and it's low libido. It is a lot to be going through in addition to what you're already going through with the cancer treatment and the cancer diagnosis in general. Not oftentimes. In the past, this was more of an issue. Now I tend to see women being treated adequately for their premenopausal or their menopausal symptoms. In the past, that wasn't really the case. If you are experiencing any of these symptoms, there are treatments. Some women are candidates, and the non-reproductive cancer patients are candidates oftentimes for hormonal treatment, which is the most effective treatment. Reproductive type cancers, uterine cancer, ovarian cancer, breast cancer, typically we treat those with non-hormonal agents, which are very effective. Things like Effexor, Brisdal can be really, really effective in patients. Even things like Neurontin can be really effective. This is important because there's something called a risk-reducing bilateral salpingo oophorectomy. That's when you remove both ovaries. This is not for a patient who's had cancer. This is for patients who are at risk for cancer. So a BRCA positive patient. This is a way to reduce the risk of ovarian cancer and breast cancer because you're taking away the estrogen. But the thing with this procedure, and we typically do this over the age of 40 or after a woman has finished having her kids, is when you take out someone's ovaries, it's not just menopause. I call it menopause on steroids. Your symptoms are going to be a little bit stronger than a woman who just goes through natural menopause. So those symptoms are more intense. So those are the women that we want to make sure we have that conversation about what it's going to be like on the other side. There was actually a study that was done by a colleague of mine who looked at women who were not counseled on what their side effects were going to be after the surgery, and they had more distress after their surgery if they didn't know what to expect. So the one thing that I always teach my patients and medical students is, when you talk about this surgery, it's not just about the reduction of risk. It's not just about the risk of cancer. It's not just about the risk of surgery either. It's about what's going to happen to their sexual functioning after. Low libido, vaginal dryness, vaginal narrowing. All of these things have to be discussed. Treatment for women who undergo premature ovarian failure. So that could be through, again, chemotherapy. It could be through radiation therapy. So women who've undergone pelvic radiation for example, colorectal cancer, uterine cancer, can all experience premature ovarian failure. Again, that's when the ovaries stop working and you go into this menopausal state. If you're not a candidate for systemic hormone therapy like estrogen and progesterone, then it would be the SNRIs and the SSRIs. So venlafaxine, which is a Faxor, it's an off-label treatment, but we use it a lot. Paroxetine, which is Paxil, which is rebranded as Brisdel, which is a treatment FDA approved for hot flashes and night sweats. Neuromodulators like gabapentin, which is Neurontin, or amitriptyline. Behavioral changes, so avoidance of stress, avoidance of alcohol, avoidance of spicy food, avoidance of warm environments. Listen, I'm not going to lie, it's not fun. I mean, a lot of women like to have their glass of wine in the evening with a meal, but then they suffer after it. This is women who've had cancer or not. This is any woman who's in the throes of perimenopause or is sort of postmenopausal. Behavioral changes are really important. So as much as you can avoid stressful situations, limit alcohol, exercise often, limit spicy things. Every woman knows what her trigger is or what her triggers are to avoid those. Exercise is really important. And there's also a lot of data around counseling. So just cognitive behavioral therapy for women who are undergoing perimenopause and menopause. And then one thing I get asked a lot often about is these are the herbal therapies that are out there for treatment of menopausal symptoms. For cancer patients, I do not recommend herbal therapies. There are therapies out there with ingredients that have estrogenic potential, so they act like an estrogen. So I typically will say for cancer survivors who have had a reproductive cancer, which is hormonally based, I tell them to avoid the herbal therapies. Radical hysterectomy, what I will say on this is that because the nature, and this is done with, for example, certain types of uterine cancer and cervical cancer, this is a more aggressive type of hysterectomy. Oftentimes it will lead to shortening of the vaginal canal. So instead of it being a 10 centimeter vaginal canal, it might be an 8 centimeter or 9 centimeter vaginal canal. So that can ultimately lead to some discomfort during sexual activity. There's also nerves that may be cut in the process that may affect sensation, may affect orgasm. The one thing that I would say about this is that if you're experiencing any of those symptoms, painful sex because you feel like the vagina is shorter, or it's difficulty achieving orgasm, or you're just not feeling much during sexual arousal, really important to talk to your clinician. There are treatments that can help this that are effective, but you have to get in on them early. It's important to get early treatment for these issues. Vulvectomy for vulvar cancer patients. We do know that there are certain factors that are associated with developing sexual dysfunction after vulvectomy. Women who are older, who already have a diagnosis of depression, who have a poor overall well-being, and they have a larger excision size. Those are the women that are more at risk for sexual dysfunction. Women who have better well-being, women who have a partner, more optimistic attitude tend to do better. And the different types of vulvectomies don't necessarily mean that you're going to have better sexual function. So HPV-related cancers, we hear about these cancers often. And I think I just want to make sure we didn't skip a slide. Can you go back one? Okay. So HPV cancers are a little bit different. So those are things like oropharyngeal cancer, vaginal, vulvar, cervical cancer, anal cancer. This is a little bit different because women will feel like, and listen, HPV is prolific in the community. I mean, 80% of women will have HPV in their system at any given time. It's very, very common. It doesn't necessarily mean it's expressing itself. Not all HPV infections will lead to cancer. In fact, most of them do not. But people who do have an HPV type cancer um, tend to have a little more psychosexual vulnerability. They feel like they got this cancer due to sexual function. That's something that I hear from my patients. They feel guilty because they think they gave it to themselves, and they should never feel that way. This is a very common infection, virus. Like I said, women and men carry it. They don't know they have it unless a woman gets an abnormal pap smear. She doesn't know she has it. And in fact, she may have normal pap smears her whole life and still have HPV. It was just never caught when she went in for her pap. Women or men and women with HPV type cancers tend to have higher levels of depression, anxiety, and anger. Colorectal cancer, again, it depends on what kind of treatment that they have, but we know that there is a higher risk for sexual dysfunction if there is radiation therapy, again, because it's typically in the pelvic region, which can lead to narrowing of the vaginal canal, scarring of the vaginal canal. If they've had any kind of operative complications, if they've ended up with a stoma, or if they're older at the time of diagnosis. And then bone marrow transplant, what I will say about that is that there are some consequences that can happen that can affect sexual function. And the biggest one is graft versus host disease. So graft versus host is something that does happen. It is very treatable. Sometimes it gets misdiagnosed as vaginal atrophy. So just bear in mind that if you've gone through a bone marrow transplant and you're having these symptoms of painful intercourse, irritation, and you've been put on treatment, but it's not working, it may be that you've been misdiagnosed. So a biopsy is always a good way to diagnose graft versus host. And this is what that looks like. You can see that picture of the vulva, which is really red, kind of patchy redness. This looks very similar to what you would see with just a woman who has vaginal atrophy or vulvar atrophy after menopause. But again, the symptoms are very similar as well. Oftentimes we treat the problem similarly. We use dilators, we use vaginal estrogen, but sometimes we also have to use steroids as well for the inflammation. So again, if you have undergone a bone marrow transplant, if you're having symptoms such as those listed, burning, dryness, irritation, pain during urination, talk to your doctor about getting a biopsy to get an accurate diagnosis. Okay, so aromatase inhibitor is very commonly used after breast cancer in postmenopausal women. It's menopause on steroids for the vagina. It's dryness, irritation, frequent urinary tract infections, decreased lubrication during sex, of course, the joint pain, the hot flashes, very common. And then with tamoxifen, we see side effects, but not as much. In postmenopausal women who are on tamoxifen, we don't see as many sexual side effects. We tend to see more vaginal dryness in premenopausal women on tamoxifen, and in the postmenopausal women, they tend to have more of a discharge, so not as much dryness. So less sexual side effects with tamoxifen. Radiation therapy. When you have radiation therapy in the vulvar, or excuse me, the pelvic region, again, you're not radiating just the cancer cells, you're radiating all the cells. And what happens is you get an inflammatory response, and that leads to scarring. And that scarring can lead to scarring in the vagina. So the vagina actually becomes shorter, more narrow. It literally, from top to bottom, it can scar down. It doesn't happen to everyone. It typically starts about 2 months after treatment, which is why for women undergoing radiation therapy of the pelvis, I often recommend using vaginal dilators, and if you are a candidate, vaginal estrogen, to keep that scarring from happening. And that dilation has to go on for almost a year after treatment. Medications that can affect sexual function negatively, obviously, anything that affects the central nervous system, that something like an anti-anxiety medication, pain medications, they're CNS depressants. So any kind of CNS depressant will ultimately cause low libido because of fatigue. It's just kind of turning off all of those neurotransmitters that are meant to help with sexual function. So I always tell patients, if you're taking any of these medications, you need to time them around when you want to have sex. So you want your pain to be at a minimum during sexual activity, but you don't want to take too much medication that you feel numb or that you just feel like you can't garner that type of libido that you need. Um, so a couple things before we jump into treatment, which are just make sure, at the time of diagnosis, if there is any kind of sexual dysfunction, if there is any kind of relationship discord, please, please, please tell your clinician, because you can get into counseling early, either by yourself or with your partner, which can be very, very effective. Also, early treatment of any vaginal symptoms. So if you're starting to have symptoms of vaginal atrophy, dryness, painful sex, tell your clinician soon, quickly, so you can get that treatment. It's most effective when it started at sort of those first signs and symptoms of painful intercourse. And then the last thing is, really talking about what the new normal is for sex. And it doesn't matter if you're a patient who is just postmenopausal or you're a woman who's postmenopausal because of cancer therapy. It's the same concerns and symptoms that you're going to have. It takes work. After menopause, it takes work to have sex. There's what I call before play, which is getting in the mood before you even get with your partner, stimulating the mind. The body is working against you. Your body after menopause doesn't want to have sex anymore, but you can develop responsive desire. It just takes a little bit of work. It takes good lubricant. It takes vaginal moisturizers, vaginal estrogen, and we'll talk about that in just a second here. So I'm going to skip through a couple of these because I want to make sure that we have enough time to get into treatment. And I pretty much talked about everything. But basically, I think this slide is really nice because it talks about improving libido and intimacy during chemotherapy. And really what it comes down to is taking time that you need. Don't rush things. Sex, meaning penetrative intercourse, should not always be the outcome. The outcome should be intimacy with your partner. Communication is really important. Having those tools that you may need to enjoy that sexual act, like a lubricant, oftentimes a sexual device. Sexual devices are what the fancy word for vibrators. A lot of women after treatment for cancer need a vibrator to help them have an orgasm. So these are all things to keep in mind. The end goal should not be penetrative intercourse. If that's what you're going for, the end goal should be intimacy with your partner. Sex can be many different things during cancer treatment and after cancer treatment. There's many different ways to have sex. So we're going to jump into treatment. This first medication that I'm going to talk about is called Flibanserin or Addy. I used to work for the company that makes this. Just full disclosure, I have no financial interest. I have no stock in the company. So I'm speaking to this without any kind of, there's nothing that I need to disclose about this. So this was the first drug that was FDA approved for the treatment of hypoactive sexual desire disorder, which is the most common type of sexual dysfunction. It's chronically low libido. Now, Addy is being studied right now at Memorial Sloan Kettering in breast cancer patients who are taking tamoxifen. It's not FDA approved for postmenopausal women, but there is data, published data, and randomized controlled trials showing that it is safe and effective for postmenopausal patients, and I do use it in pre and post. This is a drug that you take daily. It's taken at bedtime. It can cause fatigue, but what it does is increases your dopamine and norepinephrine levels in the brain. Those are the two pro-sexual neurotransmitters in the brain. It takes about 4 weeks to work. It only works in about 40% of people. The reason being, if there are multiple factors, psychosocial, relationship issues, depression, anxiety, family stress, if there's anything else going on in the relationship or in this woman's life, this drug isn't going to work, which is why it's only 40% effective, effective in 40% of patients. But when it works really, really well. Patients take it, and if there's no response by about 2 months, we stop the medication. But it's something that I have used in my cancer survivors who have chronically low libido. The one thing I would say is that in animal studies where they use super high doses, not even close to what we give to humans, like in very, very, very high studies, they did see mammary tumors, breast tumors in these mice. When they did studies in 11,000 women, they did not see cases of breast cancer over what you would see in the normal population. So breast cancer was not considered a risk with this medication. Vyleesi is the newest drug on the block for treatment of low libido. It came out a couple of years ago. It's an injectable on-demand medication. So it works similarly in the brain, but instead of increasing dopamine and epinephrine, it increases melanocortin, which then ultimately leads to elevated dopamine. This medication is given an hour before a sexual act. So you have to know that you want to be intimate with your partner. You inject yourself, and then it kind of takes effect. The one downside with this medication is it can cause significant nausea after injection. So that can stop some women from being intimate, but the impact on libido is good. If you can tolerate the medication, it actually works really well, especially for those people who don't want to take a daily medication. Wellbutrin is an antidepressant, but it also has been used in sexual medicine to increase dopamine and norepinephrine in the brain, which then leads to increased sexual desire and arousal. Women on tamoxifen cannot take this medication, but for other women, if you're looking for something that can have a positive impact on mood and also improve sex drive, then this is a medication you might want to talk about with your clinician. Buspar is another medication that's used. It's FDA approved for the treatment of anxiety, but it has been shown that when women have whether cancer survivor or not, if you're taking, for example, an SSRI or an SNRI and you get lowered libido with that medication, it's a common side effect of that medication, adding Buspar can really help as an antidote to that sexual dysfunction caused by those medications. So you can take it with a medication like an SSRI or an SNRI that caused the low libido, or you can take it on its own because it elevates, again, the dopamine in the brain. Arginmax is an herb. I don't use it much. I used to use it a lot more. It's an herb that can be used with people who have had reproductive cancers. It has some improvement. You can see it's a really small study, but basically it has L-arginine, it has Damiana, ginkgo biloba, and one other ingredient that I'm totally blanking on, but it has been shown in a small study to improve libido. I will say that in my breast cancer survivors that I've seen, this drug actually has been really useful, or this herb has been really useful. But again, limited data. If you wanted to try something that wasn't pharmaceutical, you could try this. Don't ever forget about the importance of counseling and psychotherapy. Extremely important, extremely helpful. Many women need it for their own well-being during and after the diagnosis, but also counseling for the couple as well. There is data showing that cognitive-based therapy can help with low libido. Sex therapy is really important. Sex therapists, they are therapists who have gone through extra training to understand the sexual issues and concerns for individuals and couples. I think sometimes people get a little bit tied up in the name and the language. So sex therapists are not sex surrogates. Sex therapists are like any other therapist. They take a detailed history, construct a problem list, formulate a set of goals and interventions for you or for you and your partner. The focus is almost always on the sexual issue. They're not going to be dealing with your depression or anxiety or family issues. It's just on the sexual issue. Typically, if there is depression going on with that individual, they will want that to be treated and stabilized first, and then deal with the sexual concerns. We have some wonderful sex therapists in the Bay Area, and I'm happy to share their names with you if you would like towards the end, or where you would find them. Sensate Focus is just a great way. You'll have these slides, I believe. It's a great way to reintroduce intimacy with your partner. It's a program that goes on for anywhere from a month to, it could be 4 to 6 months for some people. It starts with just creating a very romantic environment, an environment in which you are comfortable. And again, this is to bring couples back together in an intimate way when you've been separated, either because of relationship issues, because of treatment for cancer. And so you start off with just touching, no talking, and then you move ultimately to intercourse when ready, but it goes in stages. And it's a very common sex therapy technique. For women who just feel like they're not in the mood, they just don't have spontaneous libido, which is most women after menopause. Dipsy is a really great app it's basically erotic stories, and women can choose what they want, and it just helps trigger responsive desire. I wasn't in the mood. I listened to something, I watched something, and then now I'm ready to be intimate with my partner. So I call this before play. This is just a slide. I made this for a different talk. These are the messages that women get about menopause. Can menopause ever be sexy? Treating the incredible shrinking vagina. Why a woman's sex life declines after menopause. I'm a victim of identity theft. Menopause took a happy, slim, sexy woman and turned her into me. There's very negative associations between femininity and menopause, sexuality and menopause. Women after menopause can go on to be sexually active, sexually vibrant women for years and years and years. Menopause, whether it's because it's natural or it's because it's chemo-induced or treatment-induced, sex doesn't have to stop after that. That is a really important point, and we're going to talk about that. I know we only have a couple minutes left, so I want to make sure that we get into more treatment options for you. So vaginal atrophy, this is what happens after menopause when you lose estrogen and testosterone in the vulva and vagina. So this is the vulva on the left. You're looking at a woman pre-treatment with estrogen. So this is a postmenopausal vulva without estrogen. On the right is one with estrogen. You can see what happens to the vagina without estrogen. Estrogen therapy can be very effective. We do use it in uterine cancer survivors, breast cancer survivors, other types of cancer. So very important to know that you may still be a candidate for estrogen. Genitourinary syndrome of menopause is just what happens to the vagina after menopause. Dryness, thinning of the tissue, painful intercourse, frequent UTIs. We recommend moisturizers, lubricants, dilators, sometimes estrogen, sometimes non-estrogen type therapies. Non-hormonal moisturizers are a great way to start. They're over-the-counter, non-prescription. They basically replenish water content to the vagina, which can ultimately improve elasticity. They last longer than lubricants. This is not a lubricant. You don't use a moisturizer during sex. Moisturizer should be thought of as like a therapy. There are many different types: Hyaluronic, Replens, Liquid Beads, Ki. There are many different types. You just have to find the one that's right for you, but these are over the counter and a great way to start if you're having vaginal dryness. To lube or not to lube, every woman after menopause, every woman being treated for cancer should be using a lubricant. Silicone-based lubricants are the most effective. I love this. Grace and Frankie was one of my favorite shows. They made their own lubricant out of yams. Just thought I'd throw that in there. Water-based lubricants, I don't recommend them for women who are postmenopausal. I just feel that they dry up too quickly. If you want to use them, just have a spray bottle next to the bed with water. When you feel it start to get dry down there, just spray water on there. You can put more lubricant on, but water will just help reactivate. They're cheaper than silicone-based. They don't stain. They wash off quickly. They're over the counter. Most places have them, pharmacies, drugstores. Silicone-based lubricants are better in that they reduce the friction more than a water-based. You cannot use a silicone lubricant with a silicone toy. So if you have a sex toy that's silicone, you have to use a water-based lubricant. They're a little more expensive than the water-based lubricants, but they just last a lot longer. A little goes a long way. And I have no financial interest with this company, but my personal favorite for my patients is the Pure PJUR Original Body Glide. You can get it on Amazon. I just think patients love it. I mean, that's the one that they always say they go back to. Oil-based lubricants. If you want to use the natural oil, that's fine. Coconut, avocado, corn, olive, peanut, all great. Just don't use the petroleum-based or the mineral oil or the baby oils. Use the natural oils. And if you're using latex products like condoms, you can't use an oil. You can use the silicone-based or water-based, just not an oil-based. I get asked about this a lot. Marijuana can actually improve sexual function. It does improve arousal. It does improve libido. Um, do I recommend it? I mean, obviously, this is a drug. I'm not going to recommend it, but I will tell you that in California it's legal. But um, there is some data showing that it can be effective. And certainly many of my patients who are using THC products for symptoms or side effects related to their treatment have noticed improvement in sexual function. If you're interested, there is something called Foria. You have to get it at a marijuana dispensary. It's a lubricant that you use during sex, which has THC in it. Again, does have THC in it, but there's not a lot of data on this, but patients who have used it really like it. So just something to be aware of. If you're interested, you can get it in California. They also have, this brand has a CBD lubricant. So if you don't want THC, they also have CBD. Use of vaginal estrogen. Women, and we got a couple more minutes here. Women who have had breast cancer or certain types of uterine cancer, they may be candidates for vaginal estrogen therapy. Not as a first line. Your first line therapy for vaginal dryness and painful intercourse should be a vaginal moisturizer and a silicone-based lubricant. If those don't work, then the next step would be talking to your oncologist and your gynecologist or your primary care doctor about using a vaginal estrogen for a short period of time to get the vagina healthy again. And oftentimes that does the trick. And I would say at Stanford, the majority of my patients are on vaginal estrogen who have had a reproductive cancer, as long as their oncologist is okay with it. I'm going to skip to the next slide because I've talked about this. So there are different types of vaginal estrogens. There are creams, rings, tablets, suppositories. For cancer patients, I tend to do either the ring, the tablet, or the suppository. I avoid the creams because the absorption is just a little bit different. Not much, but just know that with all of these, you do not elevate your blood level of estrogen. Your level of estrogen will stay in the postmenopausal low range. This is not going to cause a recurrence of your cancer. It's not going to cause a new primary. This will not raise your serum estrogen level. And you do not need to use progesterone when you're using this. There are non-estrogen treatments for vaginal dryness. Osphena is a pill that you take orally. It's a SERM, which is a selective estrogen receptor modulator. And then there's something called progesterone, which is a intravaginal DHEA. So it's a precursor for testosterone that gets converted into estrogen in the vaginal cells. So it's called intracrinology instead of endocrinology. So it goes into the cell and gets converted to estrogen. Progesterone is a once daily treatment. I don't use it a lot. I still just use regular vaginal estrogen in my patients, but that is an option. So unfortunately, the cost of estrogen is still very high. If you compare it to treatment for, for example, Viagra for men, it's still much more expensive to get treatments to help women have sex than it is to help men have sex, which is unfortunate. Many of our patients, because of the atrophy that occurs with their treatment, the dryness in the vagina, the narrowing of the tissue, they do need to use vaginal dilators. These are just tubes that start from very small to larger. What it does is help stretch the vagina back to its normal size. I usually recommend 20 minutes, 5 days a week, using a really good lubricant like the one I recommended, the silicone-based. You can get the dilators at many different places, at Amazon, at SoulSource, vaginismus.com that now has a new name. It's called hopeandher.com, but there's many places to find vaginal dilators, and I highly recommend them if you're having sexual pain due to narrowing and dryness. These are just some more of those different dilators. The ones on top of all different colors are silicone-based. The bottom right are just hard plastic. Above that pink one on its own is called Millie. It's a self-expanding dilator that also vibrates as well if you want it to, but it starts off small and you can expand it in the vagina. And then on the bottom left is Eros, which is the first FDA approved device for female sexual dysfunction. It's a clitoral vacuum that just helps improve blood flow to the vagina, which can ultimately help with orgasm and arousal. The O-nut is great for anybody who has pain with deep sexual penetration. So if you have a toy or a penis that's pushing against the top of the vagina and causing a lot of pain, these O-nuts can actually, they're individual. So you see the 4 of them together, you can pull them apart. You can use 1, you can use 4. They go at the base of the toy or the base of the penis, and it can prevent deep penetration during sex. I'm not going to get too much into the Mona Lisa Touch, which is the laser therapy for vaginal dryness. It's not FDA approved for that reason, but it has been shown in research to be effective. This is a laser that makes these microcuts in the vagina, and over the course of a couple of weeks, you get increased lubrication. This is not a long-term treatment. You typically have to get 3 treatments 1 month, and every month for 3 months. And then a year later, you usually need a retreatment. This is an option for people who are absolutely not candidates for estrogen, who have not responded to a vaginal moisturizer. This can be effective, but just know that it is not a long-term sustainable treatment. The FDA did come down on these laser companies because they were marketing that they were a treatment for vaginal atrophy. They can't do that. They don't have approval to do that. So just know that the FDA did come down on them. Orgasm issues with any menopausal woman are really, really, they're a big issue. And so the one thing I would say is Kegel exercises to strengthen your muscles, topical estrogen. Sometimes you can just use a little estrogen cream on the clitoris that can help blood flow to that area. Vibrator therapy is imperative. Most women after menopause need a vibrator to have orgasm. The one that I am recommending to most of my patients right now, and the name is horrible, it's called the Womanizer. You can find knockoffs, and I'm gonna finish in 1 minute, I promise. You can find knockoffs on the internet, but this one has been looked at in a study to show that it does help women who have been unable to achieve orgasm to achieve it. It's just a very different type of sexual device. It's actually stimulating different nerves that are coming into the clitoris, so the main nerves that are coming in, and women will say that their orgasms tend to be more intense. They're happening quicker than if they just use their regular vibrator, which just literally sits on top of the clitoris, whereas this one goes around it. So the Womanizer, there's also a knockoff called the Satisfier that you can find on the internet. And Intensity, just for those women who are looking for a way to improve muscle tone, which will help again with orgasm. So the stronger those muscles are, the more intense the orgasm will be. This is a device called Intensity. It is a little bit expensive, but it's a pelvic muscle trainer. There's also a vibrating tip on it. If you wanted to use it during your therapy, you can, but it's basically meant to help you strengthen the pelvic floor. And with that, I'm going to end this. This is just Intimate Rider, which is a chair that can help people who have mobility issues. There's wedges and chairs. You can check it out at intimaterider.com. But for women who have difficulty getting in certain sexual positions, this can be a great device. It was designed for people with spinal cord injuries, but I've had many patients who have difficulty with arm mobility or who need a wedge underneath them, things like that. They've gotten these products and they've been very effective. So I'm going to end here. I know we sort of went all the way to the very end. I don't know if we still have time for questions or not. Is Victoria still here? Oh, she's talking. I heard you.
Yeah, so we're not gonna have time for questions, but we will be playing a short video if our audience members would like to stay on. Dr. Millheiser, thank you so much for that very thorough discussion and presentation. I really like that you were able to go through multiple pharmaceutical and non-pharmaceutical options for these women. This is a really critical topic. It really impacts quality of life. So thank you so much for exploring this topic with us today.
Thank you very much. Bye, everyone.